Good afternoon. I'm Chris Stone from University of Bristol, and I'm going to talk about a smartwatch-based smoking relapse intervention. So smoking is responsible for many deaths and serious diseases, but the consequences of tobacco use are largely preventable. If we can prevent smoking, this can result in significant health benefits, but quitting is notoriously difficult, and we need to find evidence-based, innovative methods to help smokers quit. The most vulnerable point of a quit attempt can be when the person has had just one cigarette and is then in danger of sliding back into the full-time smoking habit. Preventing a lapse in the first place can be very difficult, but if we can get to them at that point, identify that lapse whenever and wherever it happens, and deliver an intervention at just the right time, then we have a much better chance of stopping that lapse becoming a full relapse. And we use the smartwatch for the intervention because they've got sensors for tracking behavior, they've got an intuitive user interface, they're convenient and accessible, which reduces user burden and increases engagement. And to detect smoking, we developed an algorithm which processes motion sensor data and recognizes a characteristic set of movements that make up a signature gesture of smoking. And we tested this algorithm with smokers both in the lab setting and in the wild. The next stage was to build an intervention triggered by detection using messages created in partnership with the smokers themselves and delivered on the smartwatch. We designed the intervention using the person-based approach, which takes into account the views and experience of the target users. And we adopted patient and public involvement through a stakeholder group of cancer patients who provided the initial steer, a focus group of smokers who evaluated a preliminary version of the intervention, and the study participants who tested it over a 2-week period. We also involved smokers in designing the intervention messages and demonstrated the intervention at public engagement events, which provided useful feedback and ideas for the future. And to ensure we addressed a wide range of socioeconomic backgrounds in our participants, we engaged a marketing agency to help us recruit from harder to reach populations, targeting lower socioeconomic group areas of Bristol. And we also reached out to healthcare settings in the east and south of the city. Primary feasibility measures were adherence to the intervention and the acceptability of message content and timing. Secondary measures were around the practicality of using the smartwatch. And we used an online questionnaire to collect qualitative feedback on the participants' experience of the intervention. The results showed that participants wore the smartwatch most of the time. The intervention increased their awareness and allowed them to track their smoking, but it wasn't always accurate, and some participants found the notifications too strident. Most participants found the intervention messages were timely and relevant. So to summarize, a smartwatch makes a powerful tool to host a just-in-time behavior change intervention, and feasibility testing indicates our intervention was well received. There's some next steps we could do. We don't have the funding for that, but there has been a good level of interest in the media with this being featured on the front page of the Times, on BBC, ITV and Channel 4 News. So there is interest out there. Thank you for listening.
And now we have Emma Howie, real-time cognition, load monitoring in surgical teams, a wearable technology approach to enhancing team performance and patient safety. Thank you.
Yeah, so thank you. I'm Emma. I'm a surgeon and a clinical researcher based in Edinburgh. What I'm going to speak to you about today is applicable inside the OR, outside the OR, all medical professionals, and actually all humans. I want you to think about what you need to do to perform at your best in your job and what might affect your cognitive bandwidth. And then I want you to think about, if you were a surgeon, what might be affecting this. Cognitive overload, where the demands that are made onto our cognitive bandwidth outweigh what bandwidth we actually have, is responsible for 87.1% of medical errors, which is significant when surgery is a very common treatment in medicine and is the mainstay treatment of things like cancer care. Cognitive overload and stress, which is very common, especially in the NHS at the moment, can also impair our performance. So if we aren't, feeling our best, then how can we be, the best, and how can we give patients the best care? Surgeons, believe it or not, are human. But as any other humans, we're not very good at assessing our own performance, especially when we're cognitively overloaded. And it's perhaps those of us who are less competent and perhaps a little bit too overconfident that are the worst at this. So we're not very good at, actually analysing our behaviour and seeing what we could do better. The problem is we work in very cognitively demanding environments, but we don't get any feedback on how we're doing or what's affecting our performance. So you might, if you're lucky, have a comment from a supervisor or colleague in the coffee room, but that'll be retrospective, that'll be biased, nothing's changing. It's very reactive rather than proactive. So our sort of solution is to use real-time physiological monitoring. On the left here, you can see, so this is a real tracing from theatre, and the scrub nurse is, reacting to their stress levels as they're carrying out a task. And we can use this real-time monitoring to look at our cognitive load in our operating room or outside it. Our methodology uses commercially available wearable technology to measure things like heart rate variability, electrodermal activity, and complements it with existing subjective tools in order to visualize and find out what's happening to our cognitive load whilst we operate. Surgeons are involved throughout the process, the design and the implementation, finding out what went wrong, how they felt wearing wearables, etc. We are looking to involve patients, looking at outcomes of error. That's always the big thing missing in patient safety research. And we really need to move past just morbidity or mortality and really speak to patients and find out what is their best outcome following their surgery. There are numerous benefits, but in my research specifically, I look at sort of individual ways of getting support. And I've looked at personality and found, like, for example, if you are a conscientious surgeon, then you actually have higher cognitive load than someone else because you're thinking about everything else that's going on. Therefore, what can I personalize to make your cognitive load optimized for best performance? So I want to thank you, and I'll move on to the next researcher.
Thank you, Emma. Thanks, Emma. Thank you. Awesome. So next up, we have Harry Zizou, who's going to talk about towards harmonized accelerometer-derived physical activity, a comparative study across wrist, thigh, and hip wear locations. Thank you. Is the wrong one? Maybe try a different one. Let's try that. Okay.
Hello. Okay.
Perfect.
Hi, everyone. My name is Harry. I'm a PhD student at Oxford, and I'm going to talk to you about device harmonization. So if you put two paintings side by side and you really zoom in, you will likely notice a lot of differences, different brush strokes, different colors, different textures. But if you zoom out, you will realize that they're actually painting the same picture, a beautiful sunflower. And I think this is a very good analogy of what our field has been doing. We take wearable devices, we put them side by side, we compare the raw output, and then we focus on the differences. However, in today's world of international collaborations, I think what we should really be doing is bringing together data sets and large epidemiological studies and meta-analyzing that data to provide the best possible evidence to guide public health guidelines. And an issue here is the fact that different studies use different wear locations, commonly the wrist, the hip, or the thigh. And so our research question was to zoom out, basically, and not investigate how different the measurements are across different wear locations, but rather how similar they are and whether we can harmonize them. So the first thing that we did is that we looked at the agreement of wrist versus thigh worn accelerometers in the Smart Work and Life study, which has 750 UK office-based employees. And what we found was that the measurements actually showed very strong correlations across most movement behaviors. Now notice that in absolute terms, the values were not exactly the same in some cases. However, the fact that they're highly correlated means that we can likely calibrate one device against the other by using the appropriate equations. Next, we looked at the agreement of wrist versus hip-worn devices in the range study of 1,000 Australian adults. And what we found in this case was that, again, the measurements were highly correlated for most of the movement behaviors. However, the agreement was very poor for sedentary behavior on the bottom right. We hypothesized that is because of poor sleep classification from the hip-worn device. And in fact, when we repeated the study with looking at waking hours only, we found that that indeed the correlation jumped to 72%. So to summarize, movement behaviors derived from wrist, thigh, and hip locations show moderate to strong correlations, which I think shows that we may be able to use calibration equations to translate estimates between locations. And so we're now currently working on validating these equations in external data sets and releasing them to the community. So if you have access to any such studies, we're very happy to collaborate. Please come have a chat with me. And so I think these findings support the development of location-agnostic software to improve the harmonization and pooling of accelerometer data across studies, so that hopefully all of these large studies with the different devices and the different placements can help us paint a clear and shared picture. Thank you very much.
We now have Nick Hamilton, Smart Health, harnessing smartphones and wearables to transform long-term condition care.
Are we on now? Great. Good afternoon, everybody. So my name is Nick Hamilton from the South Yorkshire Digital Health Hub. I'd like to start this afternoon with a question. Please, would you raise your hand if you're over the age of 18 years old? Wonderful. Now keep your hand in the air, please, if you have a smartphone on you. That's great. You've all just met the inclusion criteria to be part of our research study, Smart Health. Now I'm going to make you a bet. I'm going to bet that if I'd asked you to keep your hand in the air if you also had a wearable device, quite a lot of you would have kept your hands in the air. And that's the same bet, as we heard earlier, that the government is also making, that by giving out wearable devices to the population, they like us, believe that this data has intrinsic value to improve healthcare outcomes in the future, which is exactly why we need Smart Health. So Smart Health is going to make this data available, smartphone and wearable data, available to researchers to help discover and make decisions about future healthcare outcomes. We're going to do this by working with 10,000 participants from across South Yorkshire who will consent to share their smartphone and wearable data with us. Now, importantly, PPIE groups and community groups have been intrinsic to the development of everything we've done with Smart Health. They've shaped and guided us since we started about 2 years ago. So our participants consent to install our app on their device, which allows them to bring their data to our research study. It's also our vehicle for asking them a series of questions, which I'll come on to in a moment. So the app gives us access to the smartphone and wearable data, and if they consent, also their GPS information. Every 3 months, we're then asking them a series of questionnaires around demographics, lifestyle, quality of life. And this is a longitudinal study. We want them to keep giving us their data. And importantly, we then combine that with routine. We've done the hard work of combining that with routine healthcare data from the NHS, both primary and secondary care. And what we're interested in is this area in the middle, this overlap of this triumph of data. What's the power of this data that might bring? So we get the data from our participants. We bring it into a secure data environment, which is hosted at the University of Sheffield. And then we talk to the ICB, who give us that routine healthcare data about the population. So that's combined with the smartphone and wearable data and the questionnaire data before it's made available to our wonderful researchers to go out and make sense of this data to make inform better healthcare decisions in the future. So as I started, I'm going to leave you with a question. What is it that you might do with this data to improve future healthcare decisions? Thank you very much.
Okay. Thanks very much, Nick. So now we have, finally in this first session, we have Hannah Wright, who's going to be talking about the Vibes project.
Thank you. So I'm Hannah, I'm a second year PhD student, and I'll tell you about my project Vibes, which stands for Vibratactile Interventions for Behavioural and Emotional Symptoms of Tourette Syndrome. So the issue that I'm looking at is tic disorders, so tics, they can be movements or sounds, and this is involuntary, and it comes with an unpleasant feeling. They can range from mild to eye blinks, sniffing to big movements that involve whole body sentences, obscene language. But there's a limited option that we have at the moment to help manage tic disorders. We've got some medication that comes with lots of side effects, and we've got some behavioral therapy that may not work and is very hard to access. So speaking to patients, so what they want is something with limited to no side effects. Obviously, that is the dream. And then something that is easy and discreet. These patients often feel like they stand out from other people in lots of ways because of their tics, so they don't want anything that will make them stand out further. And they want control and choice over their symptoms. So this tics are very much a part of them, and they may not always want to dampen their symptoms. So the solution that potentially could work is vibrotactile stimulation. So this is a small wearable device that is non-invasive, is user-friendly, and it has potential to be widely accessible because it's relatively cheap to make. So it's like having a smartwatch, so you can see up there, and it vibrates against the skin at varying frequencies and patterns. So it has been researched in Parkinson's so far, but it hasn't been done in Tourette syndrome, and there's an overlap in brain symptoms, brain dysfunction. So I have a reason to believe that it could help. So this is the first study that I did. So I had 20 participants, 12 to 18 with Tourette syndrome, and I recorded videos before, during, and after the simulation. I had the great job of counting all of those tics in that time. So I've got a number of tic frequency, and I've also got a measure of tic severity before, during, and after. And then I also had an interview with them to get the patient how they could explain to me in their own words how they felt using the stimulation and what they would want us to do if we were to take this device going forwards. So I'll just share with you some of the opinions from some of the people. We have got the data that shows there is a reduction in tic frequency and tic severity, which is really exciting. But something that we can see from the people that mattered most, I feel like I tic less. The urges inside didn't feel as strong. It'd be so good if I could have this at school. I feel so much more relaxed and like I could actually concentrate. I like just how it looks like a smartwatch, like I'm used to. People won't notice it. It just looks normal. So it seems to me like this is a really exciting opportunity, and it's something that I'm really excited to continue and work with my PPI group to see whether we could eventually roll this out to be something that was available to help people with their tic symptoms.
So first up in the next session, we have Luke Daines talking on digital signatures of asthma, mechanisms and trajectories from multimodal wearable data.
Well, what a fantastic session. And for context, this is a fellowship proposal that's been shortlisted. As a GP, I deal with uncertainty every day. But as a clinical researcher, what drives me is discovery through data to reduce that uncertainty. And one of the hardest situations I face is looking after people with asthma attack, particularly in the period after hospital admission. Make no mistake, asthma attacks are terrifying, and people with lived experience tell me that it feels like drowning. Exhausted, anxious, and in a system which can't tell them whether they're going to recover or not. The UK has among the worst asthma outcomes among high-income countries. There are 60,000 hospital admissions every year, and 4 people die from asthma every day. There is a particularly high-risk period, that after discharge, where 14% of adults are readmitted within 30 days. And this has a huge cost for individuals and their families, but also an economic cost, which is in excess of 1.1 billion for health services. The challenge that I and other clinicians looking after this group is a lack of objective markers. The physiology is being missed. But the solution is now possible. We can see early research is suggesting that there are signatures that might detect how people will recover, but also give indications of why. And now through advanced wearables, these data are available through real-world settings. My vision then is to enable proactive monitoring of asthma in daily life, with my particular focus in this critical time after discharge for asthma attack. Here's an overview of the methods that I'll use. It's a prospective observational cohort recruiting adults within the first 24 hours after admission to hospital and following them through to discharge using a second monitoring period and then at 30 days a follow-up period. The age, sex, and ethnicity matched controls will also undergo these assessments, and this will provide a richly characterized high-dimensional cohort, including wearable data, a first data set of its kind. In summary then, asthma outcomes in the UK are among the worst amongst high-income countries, and current monitoring is inadequate. Through my discovery, I will establish digital signatures of asthma and help to minimize this high-risk period after discharge and pave the way for proactive monitoring. Thank you.
Next, we have Kira Del Rey, heart rate fluctuations across the menstrual cycle. Thanks.
Great. Hi, everyone. I'm excited to be here today to talk about analyzing the effects of the menstrual cycle in digital health for two different apps I work with, one called Julie, which is a mental health chronic management app, and also I work with Flow, a menstrual cycle tracking app, and able to get heart rate data from wearables. And I actually built a package that's available on GitHub that works on R and Python, which is linked across these slides. And I'm Kira Del Rey. I'm a stats student at University of Oxford. So the motivation for this was women make up only 39% of physiology studies, a meta review found. And the main reason cited for that was because of a lack of understanding of the menstrual cycle and how it affected their outcome. So the reason it's quite tricky is because it's quite complex to analyze. So I created a package so that people without a stats background were able to analyze it with ease. All you have to do is put in the period dates, the dated outcomes of interest, and the confounders. So what this pipeline does is it pre-processes the data, so it removes errors. It labels the day from -14 to 20, which is what we found is useful in menstrual cycle analysis. It enforces a lower bound of criteria, inclusion criteria, and it normalizes the outcome. So the outcome is in a percentage mean from the individual person's difference. So it's relative for each person. It models the effects, and we wanted a modeling technique that was cyclical, continuous, flexible, and additive. So we use general additive modeling, or a GAM, with a Fourier basis. And then it also takes care of the presentation. So it's a typical GAM for each cycle, and overlaid is a linear regression so that it can, at the turning points, so that it can give you an average change per day. So this is an example of a output. And so here we all know, well, I think most of us here know what resting heart rate is. It's a biomarker that people are using continuously to look at the effects of recovery or ability to handle stress. But actually what we found from this work was that's a really predictable and with high confidence relationship of how the resting heart rate changes across a cycle. And so if you're using that as a biomarker to see recovery, you're actually either probably underestimating or overestimating, because it's never, hardly ever actually at the average point. So here, basically, you can see from the linear regression we made on top of this general additive model, you have this period from -6 days before a period, so a period is just in the middle, the red dotted line, and up to 5 days after, where you see a 0.2% decrease per day, and then the other days of the cycle you're seeing is 0.1% increase. And then as an output for mental health, so I work with Julie Mental Health, and this is for people with bipolar. They have mania symptoms. And you can see there's a really solid different trends of phases across the cycle of how they express their mania symptoms. I'm not going to read all the numbers out, but you can see it's ranging between 3 and 8, and you can be able to predict that a lot better and have a better chronic management system. I can't share all of the findings that we have because there's so many, but basically it's minutes of sleep, steps, headache, time outdoors, daily average heart rate, and it goes on and on and on. And anything that you have your data sets in, you can see if they also have the same effect. Thank you very much.
Fantastic. Thank you, Kira. Okay. Zulkin and Rashid talking about participant engagement and data compliance in longitudinal remote digital health studies. Thank you.
I think I sent this, I sent the slides on time, actually. I have my own.
You might have to talk without them. It's only 3 minutes. So.
Yeah, it's fine. I can talk without them. Okay. So I'm going to talk today about the remote digital studies and the participant engagement. So basically, I was going to talk about 3 studies. I will still talk about the 3 studies. So the first study is RADAR-MDD, which is basically a major depressive disorder study, which has participants of 623 and a follow-up period of 12 months. The second study is the participants with the ADHD who has a cardiometabolic disease. The participants are almost 510, something like this. And then the last study I was going to talk about is the story study, which is called EDIFY. It's the eating disorders with adolescent participants. And the exact number of the participants are 612 because we just finished the enrollment. And then, yeah, so we use the database platform. That's a data collection platform, open source data collection platform. You have heard already about that. The same platform which is being used in the Paprika study. So it has 2 modes of data collection. The one is the active data collection, and the second one is the passive data collection. Through active data collection, there are scheduled questionnaires which are delivered on time. And then there's a passive data collection, which are the smartphone data collection, wearables, Fitbit, Oura Ring, and this kind of data collection. And then these participants have been, oh, I got my slides. Yeah, this is the platform we are using. It's an open source RADAR-based platform. So feel free to contact us if you also want to collect data for the longitudinal studies. So this is the active data compliance. These are the number of participants, and this on x-axis there's a number of days. So these are adjusted depending on the protocols. The color you see is the participants' responses to the questionnaires. You can see on the story study, there are less responses. I will let you know in the end why. This is the passive data compliance. This is the battery data, which is being sent over a period of time by the participants. So the x-axis is the days. As I said, it's a 12 months follow-up period, and on the y-axis, these are the number of participants. Keep an eye on the story study again. So the story study is basically the young participants, adolescent participants, and you can see there is a lot of missing data here. I will let you know why. So this is the overall data compliance for the participants. On average, it looks the same, apart from on the passive side for the story study. You can see there is a high data compliance on the RADAR-MDD, which is basically a depression study, which ran for like 623 participants over 12 months period. And there was a bit slightly change of protocol during the study period, which actually increased the compliance of this study. So these are the key points. Why? So simplifying protocol and ensuring that study time is kept to minimum actually ensures better data compliance. Ensuring wearable devices are easier to use. For instance, the Oura Ring is much easier to use in comparison to the Empatica E4. Or like the Fitbit is actually very easier to use in comparing to the Empatica devices, which communicates over the Bluetooth. If the devices are easier to use, easier to manage, they will increase the compliance and engagement of the participants. And thirdly and lastly, maintaining regular contacts with the participant is very important. If you enroll the participant and engage them in the beginning, it will ensure them that they are being observed and their data is being monitored. So they will be feeling themselves accountable to remain engaged with the study. About the story study, so the young participants, adolescent participants, are different than the older participants because they don't like the study phones. They are cheaper, so they don't want to keep them all the time with them. They have very nice phones, iPhones and this kind of stuff. So they'll always like the good phones because they have a society, community. They want to go out with their friends. So they don't want to bring the old cheap phones, and they don't want to expose their conditions to their friends. So they leave their phone at home or they stop continuing the study. Thank you. Thank you for listening.
We now have up Demi O'Sheen. It's smartphone-based location tracking to predict personal sound exposure at indoor music venues and events.
Hi everyone, I'm Demi. I'm a second-year PhD student at the University of Nottingham, and my research looks at monitoring sound exposure in music venues. One of the reasons why we're looking at this is that based on the World Health Organization guidelines in 2022, over 1.1 billion young people are at risk of developing hearing loss from sound exposure in recreational settings. And what we know about hearing loss is that you can't cure it. You can only treat it using cochlear implants or hearing aids. So in adherence to the NHS 10-year plan, we're looking at preventing hearing loss in young people rather than curing it. To measure sound exposure in music venues, we install sound monitors in music venues to understand the sound pressure levels. These are great for understanding an estimate of the sound exposure levels, but they don't account for things like the position of where someone is in a music venue. For example, in a venue here, those of us who are closer to the speakers would have a greater sound exposure than those of us at the back. And that doesn't even account for movement, especially when people are leaving the venue, coming back in. The sound exposure that we measure through sound monitors is not accurate. So my project looks at installing Bluetooth beacons in venues and measuring identifying the location of a person in a music venue and using that to calculate the sound exposure. We place beacons across the venue on the walls, and these send signals to a smartphone that receive these signals. These are received signal strength signals, also known as RSSIs. These signals determine where the person is using trilateration similar to GPS. We conducted a test recently of this with 10 positions, and we found that there was decent accuracy in some of the positions, though other positions had it was quite a significant difference from where the location was compared to the predicted location. Future work in this project, we are currently looking to, we've actually submitted a grant application for this project to test this at a UK festival in Bristol, and I'm looking to conduct more tests with this project. Future work also involves looking at a different way of approaching identifying the location, which involves fingerprinting and testing the neural network on the RSSI data. Thank you for listening.
And finally, on to our last speaker, Leonid Bogachev, talking about Glucose Sentinel. So this is predictive glucose monitoring via on-body wearables for proactive diabetes care.
Thank you. Good afternoon, everyone. I'm Leonid Bogachev from the University of Leeds. I'm excited to present our new project, Glucose Sentinel. Its ambition is to build a software system to forecast extreme glucose episodes using glucose level data streamed from wearable sensors. In a nutshell, the idea is to predict adverse extremes before they happen. Why does this matter, and what difference will it make? Type 2 diabetes affects nearly 6 million people in the UK, consuming about 10% of the NHS funding. Current CGM devices monitor trends, but they fail to predict extremes. And extremes may lead to ambulance calls, hospitalization, and other interventions. Our software solution will help us to transform diabetes care, making it personalized, preventive, and sustainable. But is it possible to predict extremes? Well, for stationary data, we can use peaks over threshold models and generalized parameter distributions to capture rare events. For non-stationary data, which are much more typical for real-life applications, this approach can be extended by linking model parameters with covariates and past values. Model fitting can then be implemented using suitable regression methods. And more recently, we are looking at deep learning techniques to alleviate model assumptions. Our approach empowers efficient forecasting of extreme values in real-time data streams. Our innovative software implementation combines machine learning for feature extraction and statistical modeling for risk estimation. This invention is patented and is being used by our spin-out Forex Technologies. In the diabetes case, our proof of principle was supported by a pilot study where Glucose Sentinel successfully captured highs and lows of glucose levels. For further research and development, we are proactively applying for funding, and both these applications embed PPI work, and this includes engagement with both clinicians, for example, through Leeds teaching hospitals, and patients, for example, through Diabetes UK. Commercial prospects, we think that an effective route to market will be by integrating our forecasting algorithm with next-generation wearables. Importantly, Glucose Sentinel aligns with the NHS vision, which was discussed in detail in the morning today, which assumes moving from sickness to prevention and from hospitals to communities. Our strong team in Leeds combines expertise in medicine, data science, and innovation. We are open to collaboration, whether in algorithm development, clinical trials, or integration into health tech platforms. If you share our vision for proactive diabetes care using wearables, let's connect. Thank you for listening.